All right, Doc, you now have the floor.
Okay, thank you very much, Madam Dole Miss Jacqueline. It's a pleasure for me to be here today to talk to us on diabetes and telemedicine all combined. Today we are going to be talking on diabetes. We all know that diabetes is a condition that, when diagnosed, is usually very difficult to manage, and it requires a lot of discipline and perseverance from the patients and from the caregivers as a whole. So today we'll try to look a bit on how we can tackle this condition, even with the help of telemedicine. Okay, I'm going to share my screen. I'm sorry, I'll be using my phone because of some technical challenges I have here. Okay, for the purpose of this presentation, we'll be following this guideline. We'll start with a brief introduction. Then after that, we'll go to clinical presentation of diabetes, and after that, we'll go to the management and complications. So before we talk about diabetes, let's take a look on how glucose is being regulated in our body. When we look at this diagram, we see that immediately we take in food, the blood sugar increases, and when this blood sugar increases, there's stimulation of the pancreas, which then produce insulin, which help reduce this blood sugar, and it goes the same way around. When the blood sugar is low, there is stimulation of the pancreas, which produces glucagon, which helps to increase our blood sugar. So we see that diabetes occurs when this normal flow of glucose is altered. It can occur as a result of a deficiency in the pancreas producing insulin, or it can occur as a result of the peripheral tissues like muscles, the liver not being able to take in the glucose that is being produced. So if there's alteration in any of this pathway, it can result in diabetes. So what is diabetes? Diabetes is a chronic metabolic disease characterized by a raise in blood sugar as a result of insulin deficiency or action, or both. It is a complex chronic illness requiring continuous medical care with multifactorial risk reduction strategy beyond glycemic control alone. So as we saw in that diagram behind, we see that diabetes can occur because the pancreas is not producing enough insulin, or it can occur because the insulin produced by the pancreas is not being used. And this results in sugar accumulating in the body and resulting in a diabetes. So when we look at that pathway, we see that we have many types of diabetes. We can have type 1, type 2, and other lesser types. And we see that type 1 and type 2 are the most common ones that we know of, and type 2 remains the most common diabetes. This type 1 diabetes occurs when the pancreas is not producing enough insulin, and is characterized by severe deficiency of insulin, whereas type 2 is characterized by insulin resistance. Insulin levels are usually normal but may diminish in the long run. And we also have lesser types of diabetes like gestational diabetes, which occurs mostly which we see in pregnant women. Then we can also have other types of diabetes like we can have other types of diabetes like maturity onset diabetes, fulminant diabetes. Fulminant diabetes is a type of diabetes that is seen when the pancreatic cells are being destroyed by a viral infection. This results also in diabetes. So when we look at this diagram, we can see how to differentiate the different types of to differentiate between type 1 and type 2 diabetes. We see that type 1 is seen mostly in younger people below the age of 30, whereas type 2 is seen in people older than 30. But we should keep in mind that type 1 can also occur in people who are above 30 years, and type 2 also occur in people below the age of 30. And also, we see that according to the onset of the diabetes, type 1 is usually more abrupt, whereas the type 2 is gradual. It occurs, the diabetes onset is usually gradual. It does not just happen abruptly. It takes time before the symptoms actually set in. And the people with type 1 diabetes are usually very thin, whereas type 2 are mostly obese individuals. And we see that insulin is usually in type 1, there's insulin is absent, there's no insulin. Patient have insulin deficiency, whereas in type 2, patient is have a resistance to insulin. Insulin isn't produced, but because the insulin is not used, this results in diabetes. And we also have that in type, we also see that in type 1, you have some antibodies that are being produced. These antibodies can be the ones that are responsible for the destruction of the pancreas, whereas they're absent in type 2. And in type 1, you have ketones, which are produced, and type 2, ketones are usually absent. And type 1, they need, and immediately you diagnose a patient with type 1 diabetes, they need insulin. Insulin is the gold standard treatment. Whereas for type 2, immediately they don't need insulin, but along the line, they need insulin as years pass by. And we can also see that for complications, we have acute complications and chronic complications. And for type 1, they mostly have diabetic ketoacidosis, whereas for type 2, they have hyperosmolar hyperglycemic state. Then microvascular complications are usually rare in type 1, whereas they are very common in type 2. Same as for macrovascular complication. Then when we want to look at the prevalence of diabetes, we can see that when we look at the prevalence of diabetes, we see that the prevalence of diabetes varies with the socioeconomic status of countries. The countries that are more developed have higher chances, have more patients with diabetes than less developed countries. But this does not cancel the fact that the rate of diabetes has been growing for the past for the past 2 decades. We see that diabetes has risen from being the number 19 cause of mortality in 1990 to the ninth cause of mortality in 2016. This shows that the growth has really been consistent and is not actually a good one. On this other diagram, we can see that diabetes has maintained a steady growth from 1990 to 2015. The growth has been steady despite all the public health measures put in place to reduce the growth rate. The growth has not reduced, it is growing, and if it keep growing at this stage, at this rate, it will not be good in the long future. We can also see that diabetes, even as diabetes is growing in other areas of the world, it is the same. It has also been growing in Cameroon. Diabetes in Cameroon the prevalence of diabetes in Cameroon remain at the rate of 5.5%. We see that 5.5% of individuals in Cameroon are affected with diabetes. And it's also documented that approximately 90% or 80% of people living with diabetes remain undiagnosed. And when diabetes remain undiagnosed, most often these patients will present only with complications. So what are the risk factors of diabetes? We see that the risk factors of diabetes can be classified into two. We have risk factors that can be modifiable and some that cannot be modified. The ones that can be modified are things like age. The ones that cannot be modified, are things like age, the gender, the ethnicity, the family history of diabetes, history of gestational diabetes, and previous history of macrosomal delivery. The older you get, the higher your risk of getting diabetes. And we also see that before menopause, men have higher chances of getting diabetes than women. And we can also see that blacks have higher risks of getting diabetes than whites. Then for the factors that are modifiable, we have things like sedentary lifestyle, which is a major risk factor for diabetes. We have excessive alcohol consumption, smoking, unhealthy eating habit, obesity, and educational status. People who are less educated have higher chances of getting diabetes. So how do we die? How does it present? How does diabetes present? As we said, diabetes will present with type 1 will present abruptly, whereas type 2 is most often gradual. And this patient will present with polyuria, that is They have the patient will tell you that I urinate more frequently than usual. They have polydipsia, the urge, they taste a lot, they drink much water, and they also have fatigue. They present with fatigue, and in type 1, they'll present with weight loss due to loss of anabolic effect of insulin. And also some will present with blurred vision, fungal infection, numbness, tingling sensation in the hands and feet. When they begin to present with blurred vision, fungal infection, and numbness, you should always know that the signs of these are already signs of complication. These are signs that the complications are already setting in. So how can we diagnose diabetes? Diabetes, we can diagnose diabetes following any of the following criteria. A patient can present with symptoms of diabetes, that is polyuria, polydipsia, weight loss, plus a random blood sugar that is equals to or above 200 milligrams per deciliter. Or a patient can present with a fasting blood sugar of greater than 126 milligrams per deciliter on two separate occasions that are less than 48 hours apart. Or a patient can present with a glycated hemoglobin that is greater than 6.5%, or a 2 hours postprandial plasma glucose of greater than 200 milligrams per deciliter. A patient presenting with any of the following can be diagnosed as having diabetes. So how can we manage diabetes? How can we manage diabetes? Diabetes, we have several ways of managing diabetes. We have the lifestyle modification, we have the pharmacological methods, we have the pharmacological, the non-pharmacological, and even the surgical management. For the non-pharmacological, it's mostly diet. You can see that diet and exercise should be the ideal intervention in managing diabetes. Diet and exercise are effective, especially in obese and sedentary patients. This will improve their blood sugar controls. And though it remains the most effective method, especially in this group of people, we see that most patients will not lose enough weight to control their blood sugar level. If we are not able to control diabetes with lifestyle changes, that is diet and exercise, we can then move to oral drugs. And ideally we should start the treatment with one agent. If one agent does not work, then we can combine the treatment to two agents of different classes. Then now, if we are not able to control this blood sugar with oral hypoglycemic drugs, we can then go to insulin. But we should know that insulin in patients with type 2 diabetes, the initial treatment will start immediately with insulin. So we don't start with lifestyle modification, oral therapy, we go directly to insulin. And now, another method of treating diabetes is the surgical management. This surgical management, we have several approaches. We have bariatric surgery or gastric bypass, which is done mostly in overweight. This helps control weight gain. However, we also have the beta islet cell transplant, and this offers a definitive treatment to selected and qualified patients. This treat your diabetes for good when they do this surgery, but it's done only in patients who are qualified and are deemed and are seen qualified for the procedure. So this is the trend for diabetes. When someone is diagnosed with diabetes, the patient lives from normal glucose tolerance to pre-diabetes to diabetes. You can see that for other types of diabetes, the progression is bidirectional. So someone can live from normal glucose tolerance to pre-diabetes to diabetes and go back to pre-diabetes and back to normal glucose tolerance. But in type 1 diabetes, this progression is unidirectional. That's when you are diagnosed with diabetes, there's no going back. You cannot go back to normal glucose tolerance. As you are diagnosed with diabetes, you only progress from normal pre-diabetes, diabetes, and you begin to develop complications of diabetes it's not well if it's not well managed. So let's look at some complications of diabetes. Diabetes has several complications, and as we see, chronic hyperglycemia is associated with long-term microvascular complications affecting the eyes, the kidneys, and the nerves, as well as increased risk of macrovascular complications such as stroke, peripheral artery disease. And this diabetes also increases the risk of heart failure. Nonetheless, we also have some acute complications of diabetes, and some of them can be due to the treatment the patient is taking, or some can be due to the diabetes itself. The one that is due to the treatment is most often hypoglycemia. When a patient is overdosed, or when the patient is overdosed with medication, it can lead to hypoglycemia. And also have other complications like diabetic ketoacidosis, and we also have hyperglycemic hyperosmolar state. This The diabetic ketoacidosis is most often seen in patients with type 1 diabetes, as we saw above, whereas the hyperosmolar hyperglycemic state is seen in patients with type 2 diabetes. Then for the long-term complications, these ones are most often seen in type 2, in patients with type 2 diabetes, especially the macrovascular complication. We classify them into macrovascular and microvascular complications. These microvascular complications are things that will affect mostly the eye, the kidneys, and the nerves, and they affect the smaller blood vessels. When they affect the eye, they are often known as the most common we know is diabetic retinopathy. They will also have cataract and glaucoma, which can occur as a complication of diabetes. Then in the kidney, we have diabetic nephropathy, and we also have diabetic neuropathy, which affects the nerves. And this patient will often present with numbness. And some will have wounds. This is the most common presentation they usually have. Somebody will present with a wound on a leg that have been there for more than 6 months. They've been trying and trying and trying, and it's not going. And most often, when you want to check the blood sugar, these patients are diabetic. They will also have macrovascular complications like stroke, heart failure, high blood pressure, and they can also affect the legs, like we have peripheral artery diseases. So these are the common complications that diabetic patients will present with. So the question now that is there is, how can we prevent all these complications? There are several ways for us to prevent this complication. The first thing is to prevent having diabetes, to prevent contracting diabetes at all. So how can we educate our people on how to go about not to get this diabetes? When we look at our health system today, we see that uh, to tackle this problem, we need to first of all look at the health system, at how the health system is structured. You see that health facility, according to what we do now, patients come to the hospital for health care. So healthcare is done only in health facilities such as health centers and hospitals. But ideally, we could take this healthcare to the patients. There's what we call tax shifting. This is this is where this is a condition. This is a situation where we shift the responsibility of comparatively simple health interventions like blood pressure control, blood sugar control to health workers that are less trained with fewer qualification than fully trained doctors. And most often these people are close to the community, and they are the ones that people can easily get to have their blood pressures and blood sugars checked. And this will help reduce the risk of them presenting to hospital when complications have already set in. So we can do a task shifting. We train health workers and send them to the community to be able to attend to this to our people. Then also we see that most in our health facilities today, patients present to the hospital just for treatment. You will never see a person coming to do a checkup. They come just for treatment. Another way is that we could educate this patient. We could educate them so that they don't come only for checkup. They come even when they are not sick for continuous. They don't come only for consultation. They come for continuous checkup, like routine health checks. This will help identify this condition early enough, and we'll be able to treat them. Then also what we do now is reactive patient care. Patient come only when symptoms have already set in, but we could still give this help to the patients. They are the ones to present to the hospital. We give the help to them. They do routine check on their own, and they don't all come only when the conditions has already set in. They come early enough before the condition is even setting in. So this is basically what we can do. We do a task shifting, then we do a long-term continuous care, and we do proactive prevention, proactive preventive care, and wellness. But these conditions are this to attain this level of health system is not easy, because we need to train people, send them to the community, and we need to give continuous health talk to patients so that they can get to the health facilities as soon as possible. And also it remains difficult in our setting, especially with the bad roads, the bad even with the bad roads and the infrastructure that are not well equipped to diagnose some of these conditions. So when we look at this, we see that we can look at the telemedicine platform today, which is very very effective, which is working and is less costly. Telemedicine is a system that started since the 50s. It started in 1950. Though in the 1950s the technology was less developed. Today the technology is more developed than it was in the 1950s. By then it was used just to share maybe medical records, lab results, and some information. It was not used for consultation. But today, the telemedicine platform has developed in such a way that consultations can be done. Consultations are done, and treatments are given. Patients are given health care at home, and things like that. So when we look at telemedicine, the telemedicine is very broad, and it offers management to patients ranging from preventive medicine to specialized consultation. Preventive medicine is when it refers to the actions that are taken before the onset of a disease, which removes the possibility that a disease will ever occur. In the case of let me say diabetes, it refers to the action that it refers to the action that targets the risk factors. Like in case like diabetes here, the preventive measures will focus on those modifiable risk factors: sedentary lifestyle, alcohol drinking. We will focus on those measures to try to reduce the risk of people developing diabetes. Then also we see that telemedicine offers teleconsultation for treatment. We have first consultations, follow-up consultation, regular monitoring, patients education, and emergency consultation. First consultation provides for the is the first consultation is concerned is provided the first time the patient comes in contact with a physician through a telemedicine platform. And in this case, the patient will have a chief complaint, a family history, a previous medical history, and the comorbidities will be taken. The patient can be advised for screening, diagnosis tests, other investigation, and at the end of the consultation, the patient will have a management plan, maybe a pharmacological intervention or non-pharmacological intervention. Medication will be prescribed, and the message, the information will be recorded and stored. Then we also see that the telemedicine platform also offers follow-up consultations. Like a patient has been consulted and it needs follow-up, especially for conditions like diabetes, where a patient needs continuous follow-up. Telemedicine is very adapted to such conditions. And we also have regular monitoring. Regular monitoring, blood pressures are being controlled regularly, blood sugar, weight is controlled, oxygen saturation, all those things are monitored regularly with the help of telemedicine. And also telemedicine will offer patient education, self-monitoring of physiologic and biochemical parameters, medication adherence, administration and supervision of medicine like insulin, wound care, diet regulation, physical activities, and blood pressure monitoring. Telemedicine will offer all of this. And telemedicine also offers emergency consultation and specialized consultations can also be done on telemedicine platforms. So when we look at telemedicine, like any other system, telemedicine also has its challenges, like resistance to change. The health workers and the patient themselves, they can be resistant to change, and this can also alter this can prevent adequate flow of patient care. However, the telemedicine platform adapted to change and is also an important factor. Then we also have clinical illiteracy, lack of access to hardware and poor internet facilities. These are some challenges that the telemedicine platform will face. Then lack of availability of clinical tools. Then we also have privacy and confidentiality to health data. It is with the telemedicine platform, it's not always easy to maintain confidentiality, especially with the growth rate of hackers, but still much development has been done, and this is well controlled. We also have high cost of setting up a telemedicine platform. Setting up a telemedicine platform is usually not an easy task, and it requires a lot of resources. But what are the advantages of the telemedicine platform? The telemedicine platform has a lot of advantages in that a patient can connect to their physician at any time at the comfort of their home. You don't need to travel. You remain in your house. You consult your doctor, and he gives you a prescription, and you get your medications. Then we also have the problem and cost of traveling from one town to another is also eliminated with telemedicine. You don't need to travel to get consulted. You remain where you are and you are consulted, especially in our setting, the bad roads, the bad weathers. Most people, when they come for consultation, their complaint is the road was not easy. I could not come because it rained, and the road I could not come. There was no vehicle. But with telemedicine, these complaints are eliminated. Then with telemedicine also, you consult your physician. You can consult your physician frequently without traveling. You can access your physician at any time, and it's also very easy to maintain the medical record. I know that in Cameroon so far we have some telemedicine platforms that are doing very great. We have example, we have the fever grass that has been doing really great in telemedicine. They offer online consultations, and even on site they offer home care services, and this has really been great. Okay, this is so far what I was able to gather, and thank you very much for your attention. Take questions. I've seen some questions on the message area. Are there any studies you are currently undergoing to obtain the prevalence of diabetes mellitus in Donga Manton? Presently, there is no study that has been done to obtain the prevalence of diabetes in Donga Manton, as of my knowledge. But we are trying to see how we can conduct a study at the Ndo Baptist Hospital to know the prevalence of diabetes of patients attending that particular health facility. Okay, there is another question. Is collaborative care possible in telemedicine platform? Thank you very much for the question, Doc. In telemedicine platform, collaborative care is very much possible. The telemedicine platform will function just like a hospital with all the health personnel available, the doctors, the nurses, the counselors, the nutritionists, and other caregivers available. The only difference is that with this platform, you are not supposed to go to the hospital before you have access to these people. These people, you can get to them at the comfort of your house, of your home. You are not supposed to travel. You sit there and you consult any of them at any given point in time. So, collaborative care is very much possible with the telemedicine platform, and it has been happening. I've seen what the Fibergrass people are doing, and it is great. This collaboration is what they are using it, and is working. Okay, thank you, Mr. Nyong Harrison, for the question. Let me read the question. Is it possible to benefit from telemedicine in areas with poor or no internet connection? Are there any prospects in telemedicine out of our local service providers? How can the poor and uneducated who don't have access to gadget and internet benefit from telemedicine? Okay, thank you very much, Mr. Harrison, for this question. You remember when I was talking of the limitations of telemedicine, I talk of the I talk of the I also talk of the challenge when I was talking about on the challenges. I think I talk about the lack of ability of I talk of lack of availability of clinical tools. I talk of technical illiteracy, lack of access to hardware, and poor internet facilities. However, these conditions are not really are not really limitations. They are just challenges. Telemedicine simply means that you are consulting a patient using a phone or a laptop, and you are communicating with the patient. When you don't have when there's lack of internet connection, I think the phone can still make calls. So I think services like you can still provide a phone call, and even this telemedicine platform, they have access to the patient. They take health to the patient. They don't rely only on the technology. They take the they take the healthcare to the patient. The goal is that the patient should be consulted at their comfort. So if this patient can have you come over and see them, it's still part of telemedicine. The only thing is they need to call and let you know that they need your services, and you can still get to them. And at this time, you will not consult them on phone or using a platform, but you will consult them face to face. But they first pass through a telemedicine platform to get to you, which is using a phone or getting to you on call. I don't know if I've answered the question. Okay. Thank you very much. I don't know. Maybe Dr. Bawo Agent could throw more light. In developed countries, things are usually well set there, and us here we're still like trying to see how we can reach that level there. I'm sure that where he is, the telemedicine, he must have had experience with the telemedicine platforms, and maybe he can share some experience with us so that we can also learn and see how we can go forward.
Oh, thank you very much, Doc, for your presentation. I will first of all start by giving you a thumbs up. I mean, like taking an entire Britannica of diabetes mellitus in 30 minutes. That's the first time I've seen, because if it just like a pathophysiology or just the causes of diabetes could take like an hour or two on the average. That said, yes, telemedicine, uh, going back to Mr. Nyon Harrison, is quite a challenge in remote areas and resource limited settings. And like you brilliantly explained, uh, we are on the notion that telemedicine is either an Android app or it is an iPhone app and stuff like that, which is absolutely wrong. Telemedicine is consulting or managing condition at a distance. So even if you use like the gong, the gong that we play in the village, like you hit the gong each time the doctor is in the hospital and you hit that gong so that the patients know that, okay, the doctor is available. That is telemedicine in a very simple sense. And in areas where the population maybe do not have access to gadgets and things like that, if you have just one family in that community that has a phone, I'm not talking of a smartphone, I'm just talking of a phone, right? uh, they can create something like a small teleclinic that the other guy can come in there, sit inside, confidentiality, talk with the doctor, and leave, right? And this is opening an entirely different dimension as we see healthcare today. Because one of the reasons why you find care providers, I'm talking of you, the doctors, found in capital cities in do nobody cares to go maybe to the remote areas. The specialists are in Douala and Yaoundé. It's because of the absence of telemedicine, because once you start having platforms like this evolving, you're going to start seeing paraclinical staff. I'm talking of entrepreneurs and also nurses, laboratory scientists, start moving now to the remote areas because they know that their services will be needed in one way or the other. They will have, uh, persons pulling in to consult, to uh, do the lab tests, and then their doctors will be able to prescribe their medicines. So pharmacies and labs will be, taken to the remote areas, and that's basically what is happening here in the West. Unfortunately for us, back home, we don't yet have universal health coverage. Here in the West, in Canada, where I am, there's universal health coverage. That means that you simply have your insurance card or your health card, let me put it that way, and you consult, the physician bills your health care insurer. Most of the time it's the government, but you also have your job site that covers you as well. So it's a little bit easier that way. So the the point I'm trying to make here is we need to first of all adopt the practice of telemedicine. Once that is adopted, then the community can decide to create a plan. They can say, okay, this plan is for all our mothers or our sisters, young girls, or our children. When you use this service, it's free. The community will come together, put some money so that that service is free, right? But it's quite a challenge for us to get there in Cameroon at this time because the the practice, that's knowledge, attitude, and practices of telemedicine is is quite limited. And I really encourage some of you young doctors, especially those who are in the undergrad, please take this like some of your projects. You can even do a thesis on it. Try to get the CAP study about telemedicine. But yes, once you have the acceptance by the population, other stakeholders will pour in. So you're going to have community plans, you're going to have insurance plans, and why not? The government can decide to step in, and that will be the future of universal health coverage in Africa. Thank you.
Thank you, Doc, for the well elaborated. You have really explained it, and I'm sure Mr. Harrison is okay with that. Okay, over to you, the moderator.
All right. Thank you so much for the presentation, though. I think we have really learned a lot this evening. So we say thank you. Since there is no other question, I think we are done for the day.